I'm going to reintroduce Dr. Ahluwalia.
Hopefully, by the end of this, we will have gone through a whole host of techniques and devices, and I can illustrate to you, hopefully repeatedly, the collaboration that happens in our facility here, which is key. We maximize the skill set of every person that's involved in taking care of patients. We're going to talk about cardiovascular specialists. Now, I didn't say cardiologists, I didn't say interventional radiologists, I didn't say vascular surgeons or cardiac surgeons, cardiovascular specialists. We'll look at some of the data, but I'll try not to bore you with a lot of data. So in the 90s, early 80s, and even before that, these separate entities were treating patients quite differently. Radiologists had their skill set in catheters and wires and things like that. Vascular surgeons were making big incisions. I often say we were cutting people in half and sewing them back together. We were very good at that. Cardiologists were very good at taking care of the patient from the beginning to the end, managing their statin therapy, managing their blood pressure, and then cardiologists started realizing that the ability to do coronary angiograms could be translated into the periphery as well, and they obviously have succeeded in doing that extremely well, and I should say have probably led the charge and led the treatment options that are available to vascular surgeons such as myself. So let's just look at how big of a problem this actually is. If you take an average group medical population, and again, this is not a cardiology group, this is an average general practitioner's office, they see about 6,000 to 7,000 patients a year. If you take a couple of physicians that work together, take call together, you can see upwards of 10,000 patients. Again, the diabetes and the smoking are very, very important. Medicare has realized that, and they offer some discounts for patients that don't want to undergo screening if you've smoked about 100 cigarettes a year. So that's very, very important. If you look, the point of this slide was that only about 50% of patients that were evaluated by the physician were ever known to have peripheral arterial disease. Those are the only ones that were worked up. Of them, PAD, peripheral arterial disease, and cardiovascular disease in combination was a tremendous volume of patients. And this is clearly underscreened and under-evaluated. Now, our goal is always to treat patients before they get to this point. You can see here that this patient had a little trauma to his toe, and for some reason that toe turned black. This patient, probably diabetic, again, toe became black, and you can see this redness, which is probably a cellulitis, and God forbid this patient's foot and leg caught on fire, meaning infection set in, resulting in something like this. This is not what we want to see. We want to see patients well before this stage. And what that involves is appropriate screening by pulmonary or general practitioners and internists. And that's part of the education that we have to provide to the community as well as physicians. So how do we diagnose peripheral arterial disease? Of course, we want to start out in a non-invasive way. I always tell patients that when they first come to the office, nothing I do to them that day will hurt, okay? Obviously, after we operate on someone, we make an incision, things will hurt. But I always tell them that day, nothing is going to hurt. The first thing we do is an ankle brachial index. What that is we check the blood pressure in the arm and compare it to a blood pressure in the leg through a series of blood pressure cuffs. So we can check the blood pressure in the thigh, the distal thigh, and below knee vessels. And if we compare the blood pressure in the arm to those, we can see if there's a drop-off in the blood pressure, which would suggest to us that there's a stenosis or a blockage in the artery that's supplying blood down the leg, okay? The next step would be a duplex ultrasound, where under ultrasound guidance, we can actually see the flow velocity of the blood through the arteries in the legs. So these are all very good baseline studies, don't hurt at all. MRI is something that's at our disposal, as well as CT angiogram. The only concern that we have with MR and CT angiogram is the contrast that we give patients. Oftentimes these are very complex patients that suffer from diabetes and comorbid syndromes. Giving them a load of contrast is an insult to the body. Normal patients will be able to clear the contrast just fine, but diabetics suffer some problems with that, which is important to keep in mind. After the non-invasive studies, if there's something here that gives us a clue that the patient is not getting enough blood to their extremity, for example, we'll go to invasive imaging, which could be as simple as an angiogram, as we've talked about today, with a small catheter put into the groin, and we inject dye down the leg, and we can see directly what the flow vessels look like, and if there are any, if they're patent. We can measure pressure gradients, and an interesting topic we'll talk about in a little bit is IVUS, which stands for intravascular ultrasound. We can actually snake a catheter over a fancy wire into the vessel and take ultrasound images detecting exactly how much blockage is in that vessel, or how the vessel is stenosed and to what degree. Here's an MRI angiogram. We can see here that this is clearly demonstrating a stenosis here in the leg. This is the distal aorta, and the vessel's coming down the leg. And you can see here another stenosis as well as here. MRI angiogram is very good. The critique of magnetic resonance is that it tends to overread studies, especially if there's a significant plaque burden. Here's a on-table angiogram, which is showing a clear loss of signal from here to here, which represents a true stenosis. Now, where I trained, we were doing these open procedures, which is part of the reason why I went to train there, so that we are well versed on the open and the endovascular options. Now, surgical iliac bypass, and I'm going to show you some pictures of what this entails, is a big operation. Patient will have an incision from their chest bone down to their pelvis. They will have a graft put in that's sewn to the distal aorta. We temporarily occlude the blood proximally and distally with clamps, and patient will probably be in the hospital about 4 or 5 days. Endovascularly, what we can do is recanalize these two vessels here, supplying blood to the pelvis and the legs. Patient has 2 tiny poke holes about 1 centimeter, if that, in each groin, and they go home either that day or the next day. So let's talk about bypass surgery. The first thing I want to point out is that this point here, vein grafts versus synthetic grafts. When I say vein grafts, I either take the great saphenous vein that runs the length of your leg, I harvest that vein, and I bypass it from here to whatever target I need to bypass it to. The issue that I have with synthetic grafts, PTFE, polytetrafluoral ethylene, or Gore-Tex graft material, is fancy parachute material. Anytime we put anything foreign into the body wants to fight against it. If we do a long leg bypass, and that's our one option, and we use PTFE or plastic, and that gets infected, the patient is out of options. Okay? So I never put in synthetic grafts. I haven't done it in 6 years. Okay? So we use vein grafts. And a lot of people say, well, I've had coronary artery bypass surgery, and they've already harvested my leg vein. Well, I take the arm vein. Okay? So we always find vein. I've never been in a situation where I haven't been able to do a bypass or redo a bypass without using vein. So that's the first point. And you can see the patency is much better using vein. And why people would continue to do this, we can talk about at some other point. Now, as you can see, that when we go distal to the popliteal artery or below the knee vessels, the patency does drop off a little bit and markedly drops off with the synthetic grafts, which is another reason in my mind to use vein. If you're bypassing all the way down to here, this is about a 3-hour procedure if I'm doing it by myself. If someone's assisting harvesting vein, it cuts back the time a little bit. Patient will be in the hospital 3 or 4 days with a Foley catheter, which nobody wants, which is probably the biggest complaint I get from patients. Get this darn Foley catheter out of me. And we get them up walking, and when they go home, they're still in pain. They go home on a narcotic pain medication. Again, there are patients out there that will require this, and we do have good results. But are there other options? And yes, there are. Which one would you rather have? A 4-hour operation like this, 4 days in the hospital, or something like this? This is a dramatic picture, but you can see that the vein is the length of the leg here. Veins being harvested for a long leg bypass. Critical limb ischemia is sort of the end result of patients when they come in, and those pictures I showed you with the dying toes and the necrotic feet. These patients will likely present with complex multi-vessel occlusion and stenosis in their arteries. Again, it's multiple levels of disease in the superficial femoral artery, which is the artery that runs the length of your thigh, ultimately goes down and branches and supplies blood flow to the foot. You can see here there's a total occlusion here. Okay? And this would require a bypass from here down to here, and in my case, I would always use vein. However, with critical limb ischemia, if a patient comes in with literally a dying foot, a gangrenous foot, these patients will likely have no runoff vessels. When I say runoff vessels, I mean that in the sense that blood likes to flow. If blood is not flowing, it wants to clot. So if I establish blood flow from up here down to here, but there's nowhere for it to go, that bypass will fail 100% guaranteed. Okay? So we have to ensure that there is blood channels for that blood to bypass to and flow to. Patients are often symmetric, and the disease is often bilateral. Sometimes the anatomy is not amenable to open surgery. If the blood vessels are heavily calcified, we simply cannot put in the fine sutures that we need to create the anastomoses. So some of the techniques and devices here, we're going to go through this in a little more detail. We've talked about angioplasty, simple angioplasty, which is what is represented here. Stents we'll talk about. You can see the stent there. Various types of atherectomy. This is the laser catheter. This is something called the Fox Hollow Silverhawk, which is an atherectomy catheter. Angioplasty, cutting balloon, and cryoplasty, which was invented by Dr. Joy, the previous speaker. Can we do more than amputate? My answer is yes. When I hear that patients are told by previous vascular surgeons that the surgeon wanted to amputate the leg and let them rehabilitate with a prosthesis, that's unacceptable to me. The other thing that makes me very upset is when patients are told, well, all I want to do is heal your ulcer. If you have an ulcer on your heel or your toe, and the physician says, we're going to do the minimal procedure to heal your ulcer, that's unacceptable to me. My proponent, or my goal in treating patients is to provide them with amputation-free survival, meaning we don't amputate. Obviously, if a toe is necrotic and falling off, the toe will come off. But the goal is to provide them with amputation-free survival. And there are some institutions around the country that are creating limb loss prevention units. And I think that that's one of the things we're going to hit on here at El Camino as well. So you can see here again, here's your knee. And you have a total stenosis here. It looks like the first thing that I see when I look at these studies is the patient has good runoff, meaning that there's a target there that I can bypass to that can carry that blood. So we need to get from point A to point B. How do we do it? There's a device called the front runner, which is actually just a little hook type of thing that just pushes and creates a little wedge in the plaque that's probably been there for 10 years. That gives us a little starting point. We push through that plaque and we're able to cannulate through. And we get through to the target and you can see the end result. This is a great result, and this is not an exceptional result. This is something that we do every day. So the laser, it does exactly what is intended. You can see the change in the laser technology is improved. It actually vaporizes and creates a vaporized bubble through that plaque. It gets the plaque started so we can get our devices and fancy wires through it. Works very well. The Fox Hollow Silverhawk, which was designed by one of the cardiologists at my previous institution, uses this device here. This is just a blow-up device, or a picture of this device. It has a battery pack. It's fun to use. You turn it on. It makes a great sound. What it actually does is cut through that plaque. Once we get through it, it actually eats it up, packs it in the tip, and when you remove it, it's very rewarding to see. It's like popping a big pimple. You see all this plaque coming out of there, and it's very rewarding to see. Next, for common femoral disease, the bifurcation disease is something that I'm going to talk about in a few more slides. What we've developed here and really pushed is hybrid operations. We have facilities here, unlike any other hospital that I've ever worked at, where we have 5 rooms in the cath lab where we can do anything we want. We can operate, we can open a chest, I can do a long leg bypass, we can do all the endo procedures that you've seen everyone talk about here. We were able to open this up through an incision in the groin, about 5-centimeter incision, and we used what we call, on the next slide, an atherectomy device, which is an orbital atherectomy system. What this does is, you can see that the device is loaded and it's not completely circular around this wire or core system here. When it's turned on, it creates an oblong atherectomy, meaning the diameter that we get from it is about 1.5 times greater than the actual size of this device, okay? So it creates a larger diameter for us to work through. And here, many of you might be familiar with the rotablator. This is just comparing the two. The blood flow through here is unique as opposed to the rotablator. This is unique to the periphery. We use this quite a bit. And here it is in action. You can see that this patient had a previous stent across the knee, something we don't like to see, we don't like to do. This knee, as I'm going to talk about, the superficial femoral artery, the popliteal artery, exhibits and detects a significant amount, unique in this position, of torsion, flexion, contraction, etc., which makes it very difficult to treat. We don't necessarily like to stent across it, but again, if we have to, we have to. So you can see the stenosis here. The orbital atherectomy device is going through, and you can see the great result. Now, I'll have you notice that these channels were not open, and you can see that the channels opened up now, again, which is a benefit. We've allowed the blood flow to continue, and we've increased the amount of runoff. Now, one thing about this and what's unique to El Camino Hospital is that we see all the various techniques and devices on the market. There's not a single device out there that we can't get here or haven't used here. And the unique thing about El Camino Hospital is that we've also seen other people's complications. Okay, so we've learned and applied the problems that other people have experienced here. As you can imagine, if we're grinding through something that's thrombosed closed, where does all that thrombosed tissue go? It can go down the leg. So we've taken measures to protect the distal vasculature so that doesn't happen. The other thing is you have to know through reviewing data and being on top of these studies that when you grind up the blood tissue on those particles, ultimately they're going to find their way to the kidneys. This can lead to kidney problems. So we've developed systems and paradigms where we'll run the device, let the blood and the body clear it. And so we've adjusted our things based on the educational curve on all these new devices. That's very important. When we get to the stenting options, if we've gone through and created a new channel, what do we do with it? Oftentimes we do stent it. Sometimes we just do a simple angioplasty. It depends on the location, on the length of the stenosis, and our treatment options. SE stands for self-expanding stents. BE stands for balloon expandable stents, and covered stents. Covered stents is like putting in a graft, which is covered with that fancy PTFE material, parachute material. Balloon expandable stents is where the stent is loaded, like on Dr. Joy's previous slide, on a balloon, and you position it exactly where you want it because the balloon has markers, and you watch it be inflated. Self-expanding stents are sort of dropped, and they go. So here, one thing about the stents. All of the companies spend hundreds of millions of dollars running the stents through hundreds of thousands of simulated actions, especially in the leg. They undergo stress, they're put on fancy machines, they measure the stress that each of these struts will have. This is a metal structure. There's no perfect stent on the market, and stent fracture, as technology improves, is severely coming down, which is very, very important. But the key thing I wanted to show here was that the disease recurrence will occur at the ends of stents, okay? At the beginning of the stent and the distal end of the stent. And in this case, you can see it corresponds exactly there, there, and there, okay? So that's another lesson we've learned in terms of which stents will behave the best and most predictable way in the particular vasculature that we're working in. Now, as I mentioned earlier, the superficial femoral artery, the artery that runs the length of your thigh and branches below your knee to supply blood to your foot, undergoes all four major types of stressors, which makes it very unique in treatment. We don't necessarily like to stent across the knee again because that's a logical place where we're undergoing a lot of stress with ambulation, exercise, etc. Diffuse disease is common. We rarely see an isolated short segment stenosis or a complete stenosis in the superficial femoral artery, meaning the whole length is usually very diseased. And again, right when it crosses back into the bone, we call that the adductor canal or the Hunter's canal. That's the main area that we see disease popping up. So how do we get through some of these stenoses that are not amenable to any of the other techniques and devices we have? We have even more techniques and devices. The IVUS, intravascular ultrasound. What that allows us to do is put our catheter down across the stenosis and see exactly how bad the stenosis is, measure the luminal diameter so we can appropriately size an angioplasty balloon in a stent. This puncture needle that you see here will come into play in about, I think, 2 slides here. Okay, so here it is. So this is the plaque. We're unable to get through the plaque, so what do? We create a subintimal plane, meaning we were able to get the catheter up to this point. Now we're actually going outside of the normal lumen of the artery. We go to the other side of the artery, but how do we know that we're actually getting back into the lumen? Well, because we turn on the IVUS and we see that the blood is here, meaning the true lumen is up here. We can position the catheter and it tells us exactly which way to position that needle and fire that needle. Once that needle's in, we put an even smaller wire through that needle and ensure that we're actually in the true lumen. And then all we have to do is connect the dots. Ryan? All right, next. So here you can see we've gotten across. The needle is in the true lumen. We saw it under ultrasound guidance. Now we put a wire through that. Now we just have to connect the 2 dots. Okay. So going into the hybrid procedures. Hybrid meaning where we're doing an open procedure with an incision as well as an endovascular procedure. And we've been really pushing this here. We've enjoyed tremendous results with this, and I think it's something that's here to stay. This is for patients that have more than one level of disease, and oftentimes smokers and diabetics will present with this. Patients that have more than one level of disease will require the input of multi-specialists, which is what we have here. I, as a vascular surgeon, can perform the endarterectomy. We'll have someone else perhaps participate in the endovascular portion of the procedure, or we'll do it all ourselves. We're able to do that, and we enjoy excellent results. So basically, in a nutshell, what we do is we make about a 5-centimeter incision in the groin, which heals very well. I endarterectomize the common femoral artery. What that means is I control proximally and distally. I actually fillet the artery open, and I scoop out the plaque. And I'm going to show you a picture of that plaque. And if you thought popping a pimple was rewarding, wait till you see the plaque. So this single-setting surgery allows us to access the plaque, remove the plaque. I put a patch over the artery so that it will never and can never narrow again. So that's a one-time and done deal. Through that, we can access the patch and work either up and over to the opposite leg or directly in that leg itself. This is a one operation. Patient comes in, they spend the night, they go home the next day. So hybrid cases, again, I was alluding to the fact that we have tremendous support to do hybrid cases. They gave us these beautiful operating suites upstairs where we have all the equipment we could ever want. We can open a chest and certainly open up a groin to do these hybrid procedures. So we do the common femoral endarterectomy, we access the patch, work wherever we need to work, and this avoids, if we were to put a stent distally, but there was no blood being carried through the stent, it would logically occlude. And this avoids that poor inflow issue. So here's such a case. You can see the stenosis here in the superficial femoral artery. So we did an endarterectomy up here, and we're able to work distally, and I'll show you a little bit of that. So here's that plaque. If I was to drop this on the floor in the operating room, you would hear it hit the floor. This is actually calcium, and it's rock. I mean, it's that hard. And this is what was sitting in someone's common femoral artery, preventing blood from getting down the leg. Okay? And that's about that big. Yeah. Okay? It's very rewarding when I take this out. Okay? So here's my patch. This naturally allows the lumen to be at least 50% larger than before, thereby precluding any narrowing of this in the future. Okay? So this is a one and done. Then we access the patch with needles and wires and catheters, et cetera. We could go up and over to the other side or work distally down in the same vessel. So what we do, obviously, patient comes in that's complex in nature. We have multi-specialists seeing the patient. We have 2 sets of eyes seeing the patient, sometimes 3 or 4 sets of eyes, and we all contribute with our specialties. I'm a vascular surgeon. I worked here at HVI with doing an endovascular fellowship, so we're able to offer everyone the best option. It's no longer, well, I can only do this and I'm going to do this because you're my patient. It's not like that anymore. We collaborate. We talk every day about every patient. We offer patients the best option, and that's a testament to the Heart and Vascular Institute and the way it's run. So let's just touch very quickly. I'm running out of time. Carotid artery stenting. You can see here this is an angiogram. Multiple complex issues here, swirls, curlicues in the carotid artery. And here, down here, you can see the very tight stenoses. How do we treat that? We can treat this in a hybrid fashion as well. We are able to treat this endovascularly. You can see a catheter going up right here. And you see the tight stenosis, with which is the blood vessel that's supplying your brain. Very, very important blood vessel. I only have one. I'm just kidding. So FDA-approved stents and filters. There was some question earlier about the protection, cerebral protection with Dr. Vial's talk. No stent filters all of those emboli. Doesn't happen. Not a single stent on the market does that. The European data has shown that sometimes the stents may not even be necessary and may be detrimental, but that's not the topic of the talk here. Anyone that has a carotid stent done in the United States is going to have a filter placed. So here, very quickly, you can see the catheters down here, and the stent is deployed. This device right up here is the embolic protection device, the EPD. It looks like an umbrella, and you can see the stent deployed appropriately. And here I just want to show you the picture of some of the debris that's caught in that device. Very telling. So patients, I'm not here to tell you that one path for every patient is the best option, but I am here to tell you that multi-specialty collaboration will reveal and result in the best patient outcomes. And that's it.
Thank you very much.
Thank you.
Well, good things are worth waiting for. We'll take some questions before we go on to our last topic and final question and answer period. That's it.
I know that stents that release over time, medicine have been developed, as well as stents that dissolve after time. Does El Camino uses them, or are they not?
So we use, every stent on the market is available to us here, but the key thing with the stents is choosing the right one for the right problem. The drug-eluting stents, most of the data is coming out of the coronary literature, putting the drug-eluting stents in the coronary vasculature. There are some indications that putting it in very complex restenoses, and et cetera, has had good results, but the data's not out yet on those stents. There are stents that dissolve, like you said, as well, as opposed to the drug-eluting stents, and the data's not out yet. Stay tuned. Hopefully by next year we'll have some data for you.
Question? Please.
What are the symptoms of this disease if your toes aren't bloody?
Sure. It can be very simple as when you walk.
Repeat the question. She's saying, what are the symptoms if you don't have evidence for gangrene?
So the biggest complaint that patients probably walk into the office is with when they say that a year ago they were able to walk out to a fixed distance, whether it be the post office box or they were able to go and do their grocery shopping. And now they have to turn around, at the grocery store. They can't push the cart or they can't make it out to their mailbox. That entity is what we call claudication. A fixed distance of ambulation causes a patient to have pain. You have to imagine that the blood supply is not going to the muscle. It's like when you're doing a bench press or exercising. The muscle is starving for blood and causes you to have a cramp. So that's one of the things. Simple swelling and edema and pain at the end of the day when you become recumbent, because gravity is no longer helping carry the blood down to your foot. So some of those are the common things, as well as lesions.